Get out of the spotlight. Thanks for coming in for lunch for our lunchtime speakers. I'm going to introduce our first speaker of the afternoon, and this is Lorena Martinez. She is a second-year emergency medicine resident at the USF Emergency Medicine Residency over at Tampa General, which is a local, very busy level 1 trauma center. And she did her she went to medical school at Nova Southeastern in Fort Lauderdale and did her undergrad at UF. Just something interesting about her, she's the first doc in her family, and she is a semi-pro organizer and self-diagnosed herself with OCD. So, thank you so much.
Well, thank you, Dr. Hansen. Hi, everyone. So I'll be talking today about the basic point-of-care ultrasound evaluation for suspected pulmonary embolism. I have no financial interest or relationship to disclose at this time. So our objectives here today is to teach you a little bit about the different cardiac views and how to use the phase array in terms of where the point indicator goes and the anatomical location to get those cardiac views. Obtain some basic understanding on the various ultrasound techniques specific for right heart strain, as well as some basic understanding of the various ultrasound techniques that are highly specific for pulmonary embolism. Also, can you guys hear me okay? I don't know if this is like, okay, perfect. So I'll start up with a case presentation. This is a 67-year-old female. She's coming in by EMS, secondary to lethargy and altered mental status. On EMS arrival, they found her to be bradycardic at 30, in the 30s and hypotensive. Per report, she hasn't been feeling too well for the past day, doesn't want to get out of bed, refusing to eat. Given the findings by EMS, they administered 1 milligram of atropine, 500 milliliters of NS, and started her on norepinephrine and transcutaneous pacing as well, which actually resulted in some minimal improvement of her vital signs. However, her alertness and mentation continue to be pretty much the same, very minimally responsive. We also learned from EMS that she has a history of stage 4 pancreatic cancer, for which she was being treated, but that was paused about a month prior to her presentation, secondary to very progressive weakness. Otherwise, the history was limited by the fact that the patient was pretty much minimally responsive, not talking to us. Her vital signs on arrival were temperature of 96.5 degrees Fahrenheit, heart rate of 51 beats per minute, blood pressure 93/79 millimeters mercury, respiratory rate of 20 breaths per minute, and O2 saturation of 99% on a non-rebreather. So as emergency physicians or, providers in the acute care setting, first thing we're going to do is our ABCs, primary survey with airway, breathing, and circulation. So looking at her airway and her breathing, she's minimally responsive. She's not protecting her airway. She's not really talking to us. She's tachypneic. If we take her off the non-rebreather, she's becoming hypoxic. So we went ahead and intubated her to assist with ventilation, airway protection, and oxygenation. So moving on to her circulation, we know that she was initially bradycardic and required some transcutaneous pacing. She was hypotensive on initial presentation by EMS, and she's been responding to some fluid and norepinephrine. So now she's pretty much normotensive. Nonetheless, we still need to find out what's going on, why is her heart bradycardic, and what's causing this hypotension. So two best ways to do so here. One, EKG, we want to know what her heart is doing. And two, my bedside ultrasound. We have a patient that has a history of cancer, has been minimally active, is pretty much hemodynamically unstable. So we want to see what's causing her state of shock in this case. And one of the best ways to do this is doing a bedside ultrasound of the heart. So we obtain her EKG, and we find her to be in a 3rd-degree block. We see P waves that are pretty much regular in nature, but have no relationship with her QRS. So we have an idea what's causing pretty much her bradycardia here and potentially her hypotension. Nonetheless, we're not going to stop here, and we want to get more information. So we throw an ultrasound probe, specifically the phase array probe, or what we call the cardiac probe as well, on her chest, and we obtain this view right here. Anybody knows what this view is by any chance? Don't be shy. This is a parasternal short view. And we get this and we get a little concerned. Anybody knows why? What is this right here? I guess this chamber right here. That's the right ventricle. Good job. So we see the right ventricle, and it looks pretty big. Normally, the right ventricle compared to the left ventricle is about 1/3 of that left ventricle. It should not be larger than the left ventricle itself. The other thing that we notice here is that she has a flattening of the septum right here, kind of causing an oblong shape of that left ventricle. The left ventricle should normally be a nice circle. It shouldn't be as flat and oblong, and in this case, so we'll talk about this a little bit more later. I don't want to give it up right now. So now we're a little concerned. We see that her heart, she has some right heart strain pretty much, right? And we're worried that she could be having maybe an acute pulmonary embolism that could be causing her hypotension. And normally we see, obviously, with acute pulmonary embolism, a tachycardic patient, but maybe that's being masked right now because she's also in a 3rd-degree heart block, right? So with that being said, I'm going to use this as a segue to talk a little bit about what are some of the signs that we should be looking on ultrasound if we are trying to rule in or rule out pulmonary embolism in our hemodynamically unstable patient in a state of shock. So when I think of pulmonary embolism and echo, I pretty much think immediately of right heart strain. That's what I'm pretty much looking at here. I wanna see, the right heart is not gonna be functioning the way it's supposed to be functioning, and we're gonna talk about different signs that we're gonna that are gonna be able to tell us if this is something acute versus chronic, and acute versus chronic. So before I move on to those signs, I kind of want to touch bases on how to obtain these cardiac views. So as I mentioned earlier, we're gonna use the phase array, which is like kind of like the square-looking one out of all the probes on the ultrasound machine. And we all know that the probes have a probe marker, right? So we have 4 views that we want to obtain on a cardiac ultrasound, and that includes the parasternal long axis over here on the top left corner, the parasternal short axis on the top right corner, the apical forechamber, and the subxiphoid view. So to begin with the parasternal long axis, we want that phase array on the 3rd to 4th intercostal, right along that left sternal border, with the probe marker pointing to the right shoulder of the patient. So it's kind of angulated to the right shoulder of the patient. And the view that we're going to obtain here is going to have the right ventricle followed by the left ventricle and the aortic outflow tract. We see mitral valve and the left atrium. One thing that I will add here, I like to also include in this view my descending aorta. So normally you're going to see a circular structure down here. So I always optimize my depth to make sure that I'm including my descending aorta in that view as well. To obtain the parasternal short view, all I have to do is rotate that phase array probe in a 90-degree fashion with the probe marker pointing to the left shoulder. So you're still in the same position. You find that parasternal long, and then you just rotate 90 degrees to point to that left shoulder, and it should give you this nice circular left ventricle, and next to it the right ventricle. And in this particular view, we can actually fan our probe either up, so the probe base points towards the right shoulder, or all the way down so it could point towards the left hip. And when we do that motion, we're kind of ranging throughout that left ventricle and right ventricle, and to bring into view other structures that we're going to talk about later. For the apical forechamber, so this one actually, this is one of my most challenging ones to get on the screen and have that perfect vertical view like we see over here. But all I do for this one is kind of like move from wherever I found that parasternal short and kind of move towards like underneath the nipple at the 4th to 5th intercostal space. And then make sure that my probe marker is pointing to the left side of the body of the patient. And you should bring into view your right and left ventricle, as well as your right atrium and left atrium. With this fashion here, with the vertical fashion, so the section should be very vertical in the center of that screen. Finally, the subxiphoid, we have the face array with the pro marker facing to the left side of the body. And we're literally just going underneath that xiphoid and pointing up towards the heart. And in this view, we're going to bring, pretty much we're going to see our liver. So if you're ever wondering what kind of view this is and you don't have like something to tell you, if you see a liver, you're probably subxiphoid because you're cutting through the liver to look at the heart. So we're going to see the liver, then followed by the right ventricle, left ventricle, the left atrium, and the right atrium. Okay, so like I said earlier, when I think echo and pulmonary embolism, I'm looking for right heart strain. So what are some signs of right heart strain? So the first one we talked about it earlier, that was the large right ventricle to left ventricular ratio. So in this case, in this view right here is not the most optimal. What view is this again? This is an apical fourth chamber. So not the most optimal apical fourth chamber, but we can appreciate here the right ventricle, the left ventricle, the right atrium, and the left atrium. And if you notice, you can see that this right ventricle looks a lot larger than the left ventricle. So I know something is definitely going on that is increasing the pressure in that right ventricle. This gets really worrisome when we have more than 1-to-1 ratio. Sometimes the right ventricle could be a little bigger, and that's okay. But when it's more than a 1-to-1 ratio, like in this case, I will definitely be worried that something's going on here, whether it is acute or chronic. The other thing to keep in mind is a rule of thumb is this whole length right here, we can think that the left ventricle spans about 2/3 of that length in a normal patient, and then the right ventricle span maybe about 1/3 of that. So in this case, you can see that the length of the right ventricle is a lot longer than that. Obviously, the sensitivity and specificity of this for PE, really low, because anything that causes strain on that right ventricle is going to cause the right ventricle to turn large pretty much. But we'll talk about other signs that are going to be a little bit more specific shortly. So just to give you a quick view of what normal looks like versus abnormal. So this is a normal view right here. There we go. So we can see that that right ventricle is a lot, on that picture on the right ventricle is a lot smaller than the left ventricle, and that's a normal ratio right there, versus this one is our patient that had a very large right ventricle right here compared to that left ventricle. So one of the most optimal views to obtain to see that ventricular enlargement will be our apical fourth chamber, but I also like a lot the parasternal lung axis. That's because we have like a rule of third that kind of help you determine if the right ventricle is enlarged. So in this normal view right here, I'm just gonna pause this real quick. We see the right ventricle, the aortic outflow tract right here with the aortic side of the aorta, and then the left atrium. And these three structures should be about the same size. So they're about 1/3 of that left ventricle. So we can tell here that they're about the same size. Looking at our patient parasternal lung axis, we see that her right ventricle right here is a lot bigger than this aortic outflow tract right here. And then her left atrium also looks very enlarged. So maybe she does have some sort of heart failure, even though her left ventricle looks like it has a good squeeze, good ejection fraction per se, but it's definitely a lot smaller than this right ventricle right here. So that's another way to determine whether or not the patient has an enlarged right ventricle. Okay, so the next sign that I'm gonna move on to is one sign that we talked about earlier when I first presented that parasternal short axis view. Is something called the D sign. So the D sign is actually an echocardiographic finding that shows the left ventricle as a D shape. That's literally what it is. D sign, left ventricle looks like a D shape. Like I mentioned earlier, it should be a nice circle. And in this case, if we look at this picture right here, this ventricle is being flattened by the pressure or volume overload, the right ventricle, to the point that it's making this form a D sign. We can further talk about design by talking about the eccentricity index. So in a normal ventricle, if you measure the perpendicular measurement from the septum all the way to the free wall of that ventricle, or the parallel measurement to the septum, like we have right here, D2, we see that those two lines are pretty much the same length, perfect circle. So that eccentricity index is 1. But in the case of a D sign, or when we have a right ventricle increased pressure or volume overload that flattens that septum, we can see that that left ventricle becomes a little more oblong and makes the D2 measurement, that parallel measurement, a lot longer than the D1 measurement, giving you an eccentricity index of 1. And then we can further break this down into pretty much whether this happened throughout the entire systolic and diastolic function of the heart, or if this is just happening during diastole per se, and that will tell you a little more in terms of whether this is volume or pressure, but I'm not going to be touching bases on that today. So just to show you a little bit more about this sign, this is a normal patient right here with our perfect circular left ventricle, and this is a picture that I borrowed from the web that shows that D sign right here with that flattened septum and that perfect D-looking left ventricle. And then just to give you a little bit about sensitivity and specificities, this sign unfortunately is non-specific for PE. However, it gives you another reason to think there's right heart strain, obviously, and in the right clinical setting, this could probably rule in PE, and you could continue with the next step in terms of doing the confirmatory story / treatment for it. The next sign of right heart strain that I'm going to talk about is called tricuspid annular plane of systolic excursion. Try to say that with a mouthful of food or very rapidly. So we call that TAPSE for short, because as you can see, that's very long. But this is just pretty much the systolic excursion of the right ventricle. So it's looking at the lateral tricuspid annulus, which is kind of at the base of the ventricle, and how that motion goes towards the fifth apex. So it's kind of essentially like the ejection fraction of the right ventricle. How well is that ventricle pretty much contracting? And in case of right heart strain, that ventricle is not going to contract as well, right? So with TAPSE, the way we measure this, we're going to have our apical four-chamber view, and then we're going to bring in something called motion mode, or N mode, okay? And that's going to bring this cursor that we see right here. Normally, this cursor will probably appear in the middle of your screen, and all you have to do is drag it all the way to that tricuspid annulus, and then just hit that M mode one more time, and you're going to get this nice little graphic down here. And this wave that you see here is pretty much the systolic and diastolic motion of that wall. So all we're doing here is pretty much measuring the distance between the peak and the nadir of this particular wave right here. So nadir is at this level right here, right here, and then the peak is right here. So it's measuring this distance right here. And a TAPSE less than 1.6 centimeter is actually consistent with right heart strain. So a normal TAPSE is 1.6 and above, and that would tell me that there's normal motion. If it's below that, then I'll be concerned that there's some right heart strain. This one is actually about 72% sensitive for PE and 66% specific for PE, so not so specific. However, in a patient with tachycardia or hypotension, the specificity can go a little higher to like the 90s. So the next sign I'm going to talk about, and this one actually will help me determine whether or not there's an acute versus chronic right heart strain, is the 60-60 sign. So the 60-60 sign, I really like this graphic a lot from core ultrasound. Pretty much measures the pulmonary artery systolic pressure and the pulmonary acceleration time. So to measure the pulmonary artery systolic pressure, you're bringing the heart in an apical four-chamber view, and you're going to use, in this case, the continuous wave. So once you activate the continuous wave, you're also going to get a cursor that's going to come in the middle of the heart, and then you're going to hit that continuous wave again, and you're going to get this like blood flow graph down here. And all we're really doing is measuring that peak right here from base to peak of that blood flow, pretty much that swath right there. And it'll give you a pressure. And in the case of an acute process, that pressure is normally less than 60 millimeters mercury, which suggests pretty much acute PE. For the pulmonary acceleration time, all we're doing is putting the phase array on a parasternal short axis. And like I mentioned earlier, we can fan it either up or down to bring other structures into view. So if we fan towards the right shoulder, normally we're going to bring this Mercedes Benz sign right here, which is our aortic valve. And when we bring the Mercedes sign or the aortic valve into view, we're seeing the right atrium right here, adjacent to it, followed by the tricuspid valve, followed by the right ventricle, and finally by the pulmonary valve and the pulmonary artery. So in this case, what we're going to do is that we're going to activate our pulse wave source of the ultrasound, and it'll bring this cursor right here. Normally, these two marks, we're going to want it probably a little bit more proximal to this pulmonic valve. And then we're going to hit the pulse wave one more time, and we're going to get another blood flow wave like we see down here. And all we're doing is measuring that acceleration time from the beginning of the wave all the way to the peak of the wave. So you're pretty much starting your measurement here and then extending it to go towards that peak, and it'll give you an acceleration time. If the acceleration time is less than 60, that's normally a sign of an acute process, and in this case will be acute PE. So to show you how that works here, this is the pulmonic artery systolic pressure. And like I said earlier, you bring that apical for chamber view. This one is not the best apical for chamber view, but this is the right ventricle right here. We activate the continuous wave, and then we will measure pretty much from baseline to peak. If it's less than 60 millimeters mercury, it's an acute process. In this case, same idea, we have our parasternal short axis, and then we're pretty much bringing, this is our Mercedes sign right here, we're pretty much bringing that pulse wave cursor right here to the pulmonic valve, and then we're measuring from the beginning of the wave all the way to the peak, and it'll give you a time, in this case was 55 milliseconds, I'm sorry. So that will also be a sign of an acute process. Lastly, I'm going to talk about early systolic notching. Early systolic notching is pretty much, we use the same idea of the parasternal short to be able to measure that. And we're using our pulse wave, and we're going to get that typical wave that we saw earlier with this pulmonary acceleration time. And the idea here is that we're going to have a spike and dome morphology of the actual wave. So if we look at this wave earlier, sorry that I'm going back, it's kind of like it spikes and then it's continuous, right? Versus this one right here, it spikes and then it has this notch, and then it kind of had that curvilinear notch done after. And the idea is that the spike happened in the first 50% of that blood flow or that wave right there. And in the case of early systolic notching, that's also very consistent with an acute process of right heart strain. This one has a sensitivity for PE of 92% and a specificity for PE of between 92 and 99%. So very sensitive and specific as well. When you combine pretty much all the signs that I just talked to you about, if you're doing all these signs on your patient, you could almost approach a specificity for PE of like 100% and almost rule out PE if all these signs are negative pretty much. And when I say PE, I'm usually referring to as massive versus submassive PE. Subsegmental PE will have different sensitivities and specificities. So obviously, we talk about the right heart strain sign, and we've been talking a little bit about how to determine whether it is acute versus chronic, but other things to take into account is past medical history. Like I mentioned earlier, our patient was altered, and we weren't sure we were dealing with something acute in this picture, but once we stabilized her a little bit, we were able to obtain a little bit more information, and we learned that she actually has a history of pulmonary hypertension, which was probably the source of her heart strain in this situation. And we also probably know that because her right atrium was very, very enlarged, meaning there was some sort of time that went by that allowed for that right atrium to enlarge to accommodate that increase in pressure that was kind of pretty much flowing backwards in the wrong direction, if that makes sense. Aside from that, she was also on Eliquis for atrial fibrillation. So, you know, we were concerned because of her history, given the cancer, her immobility for the past few months. However, she also was on Eliquis. Daughter said that she was pretty consistent with it. So with that being said, the chances of PE in this case are pretty much lower because she's on an anticoagulant, right? Another thing that we could do also is measure the right ventricle free wall thickening. So the best way to probably do so is on the subxiphoid view and at the end of diastole. So as we see here, we see a little bit of liver, and then we're bringing this right ventricle into view right here. And what we're doing is pretty much measuring from the epicardium, the edge of the epicardium, all the way to the endocardium. A normal measurement here will be less than 5 millimeters. Anything above that means that the ventricle is thickened or enlarged. The wall of the ventricle is enlarged, and that means, you know, heart is a muscle, so if we work it out, it's going to get thick. So the idea here is that if you are working against a higher pressure for a long time, it's going to thicken up. So that would tell you that this is a chronic process if it's thickened, versus if it's not, it's an acute process per se. I'm probably homing P a little more than any other chronic process. And then finally, the McConnell sign. This is one of my favorite signs, actually. So McConnell sign is pretty much when we have the right ventricle, we're looking at the heart in the apical four-chamber view, and we have the right ventricle. And what you're going to see here, and so this is our patient right here, right? But if we compare it to this one, we see that there's some akinesis of that right ventricle free wall right here. It's not really contracting, right? It's not really moving. But then we see like this trampoline. Oh, where did my cursor go? Right here, we concentrate on the apex. You're going to see that it looks like a little trampoline. You see it going in and out, going in and out. So that's what we call the McConnell sign, where we have the apex motion of a trampoline, but the free wall is actually akinetic. As compared to our patient, we're not really seeing that motion. All we're seeing is the right ventricle contracting. We don't see that trampoline motion. And McConnell sign is actually one of the signs that is very specific for PE in the right setting. It has a specificity of about 94 to 96%. But it has a very poor sensitivity. So if it's not present, it doesn't necessarily mean that we're rolling out PE. I know that was a lot of information, and I went a little fast. But if you have any questions, feel free to let me know. And these are my references.
Next up, we have Dr. Darrel Ray. He is our current ultrasound fellow at USF at Tampa General Hospital, and he did his residency at Sarasota Memorial Hospital, now in Sarasota, Florida. And he's got a great case to present. Dr. Ray.
All right, thank you. Excuse me. So Lorena presented a great case, and kind of contrary to how she took you through her case, I want to present on how ultrasound can really benefit in the critical patient. This is a case that just back in May, so as a third-year resident, was working overnight. I was on the trauma ICU, and I had another third-year resident that was working in the ED. So this was his patient primarily, and I was there assisting him when we went through the patient. Lorena did a great job talking about all the different signs. You've had great instruction so far on how to obtain the cardiac views. So mainly we're going to focus on how quickly we can come to a diagnosis, how we can kind of move along care pretty quickly in the critical patient. So it was overnight. I'd just gone to Sano games. That's me there in the middle. Our team, we were the megahertz. We were, like pro wrestlers. We'd placed in the top 10 nationally for Sarasota at the Sonic Games in New Orleans. We were the #1 program in Florida when it was all said and done, so we did pretty good there. I was busy working overnight, feverishly working on a textbook chapter, so I was feeling pretty good about my ultrasound skills at the time. A co-resident kind of let me know, he's like, hey, I got this hypotensive patient. I might want you to go and do an ultrasound. So I was kind of just hanging out looking for procedures, for ultrasounds, whatever I could do while we were working overnight in the trauma ICU. Someone else had asked me to do a regional anesthesia for a hip fracture, so I was going to go off and do a block, and I was going to kind of meet up with him a little bit later. So our patient, very similar to Lorena's patient, so 49-year-old female. This is 3 o'clock in the morning. She was in moderate distress, kind of like Lorena's patient, kind of fatigued, not really able to provide much history. Husband was saying that she has a history of metastatic non-small cell lung cancer, was on immunotherapy and chemotherapy. She'd just been having more fainting episodes, more fatigue and syncope. She'd fallen, possibly hit her head. No allergies, no prior surgeries. Vital signs concerning, she's hypotensive, 88/69. Mildly tachy, she had no temp. Her room air sat was fine, breathing a little bit fast, but clear lung sounds on exam. No murmur, scalps or rubs, no extremity edema. Initially, pretty broad differential to consider in this patient. She's certainly in shock with her presentation, her vital signs. Certainly could be distributive shock, obstructive shock, cardiogenic. There are plenty of other things to consider here. So rather than put a probe on her chest, he started the workup, with, first of all, kind of a nurse-initiated physician protocol set, getting an EKG and basic labs, started a sepsis protocol, gave her some bolus fluids, broad spectrum antibiotics, a chest x-ray, CT head since she had the syncope and fell, and the CTA of her thorax, because I think he was thinking, well, she's a cancer patient, she's more likely to have a PE. She wasn't on any anticoagulation that we were aware of with the low blood pressure and the syncope and everything. So eventually we're going to get to the diagnosis and starting the resuscitation. This is a patient that requires resuscitation before she needs to leave the ED. And kind of getting that started. So the first bit of data that we get back is the EKG. So this is an EKG that I didn't see, has pretty characteristic findings for a patient with cancer. Just take a quick look at that there. So her vital signs, she came in about 3 o'clock in the morning. Her heart rate stayed pretty stable. Blood pressure dropped a little bit, and then you can see about an hour into it, after she got, 2 liters of fluids, that kind of came up a little bit, but the heart rate stayed kind of persistently tacky. Wasn't a very busy shift. She was in the critical care pod. Nursing was free to kind of focus on her and get things going and move along for her. So blood work starts to come back. The times there in the upper left, 3:30. That's usually the time that the lab kind of gets the blood and starts processing things. Blood was drawn right away when she came in at 3 o'clock. A lot of red arrows. I mean, her potassium's fine. That's great, but everything on her is looking pretty bad. A lot of kidney problems. The white blood cell count's elevated, kind of what we'd expect with kind of a septic shock picture. Some additional labs kind of come back. Lactic acid's elevated, lipase, livers, LFTs, troponin, proBNP, and then a chest x-ray. And so notice the time on the chest x-ray. We're 4:35. So now we're about an hour and a half into her stay. We have a presumptive diagnosis. Maybe this is a septic shock. Not really certain of a source just yet. Urinalysis is still pending, and they finally get a chest x-ray, and this is what it is. So single AP of the chest, no real obvious pneumonia, kind of a large cardiac silhouette, No pneumothorax, no tension physiology there. So by the time I'd gotten done with my nerve block and kind of came back, I was going to go and ultrasound the patient. She wasn't there. She was already in CT. The CT images, they got done probably around like 5 o'clock. The other resident scanned through everything. There's no real obvious PE, no massive, submassive PEs or anything like that. And then we kind of look and trend her vitals a little bit more. So blood pressure is getting worse and worse as the time goes on. We're kind of spacing out our vitals a little bit closer together. She has to be started on Levophed because she's just getting persistently hypotensive. So as me and the other resident were kind of talking about all of her history, and it's not PE, sure it could be sepsis, but then looking at that EKG that had the electrical alternans and that large cardiac silhouette on the chest X-ray, it's kind of like a light bulb clicked. We kind of like looked at each other like, yeah, we kind of, are you thinking what I'm thinking? We need to go and ultrasound the patient. So we grab the ultrasound and we go in there, and where do you want to start? Like the way that I approach critical patients is I like to start with the heart, the rush exam, the rapid ultrasound for shock and hypotension, heart, IVC, Morrison's pouch, aorta, and pulmonary, kind of the order that they kind of take things in, but based on your clinical suspicion, you can start anywhere. And seeing her EKG, the large chest, cardiac silhouette on the chest X-ray, went right to our heart. This is what we see. So parasternal long axis view, we see a large pericardial effusion, and kind of putting it all together, we have a high suspicion for cardiac tamponade. So time there is 5:30 in the morning now. So 2.5 hours after her initial presentation to the ED, we finally get a probe on her chest. That was 2.5 hours. But in 6 seconds, we know exactly what's going on and what we need to do. So we could have decreased our time to diagnosis, actions that needed to be done, and get her taken care of right away. So I know some people have a mindset that ultrasound may kind of slow me down. I have to put in an order to get the patient's information into the machine or enter it manually. But in this case, in a lot of cases for resuscitation, it'll really speed up your time to disposition, and it really guides your workup. Did she need the sepsis fluids? Maybe not sepsis fluids. We probably just need to relieve the strain on her heart. Did she need all the antibiotics? Maybe, maybe not. She'd have the elevated white blood cell count, but with really no source. So a lot of good things can come from using ultrasound in resuscitation. So going on to our next view of the heart. So we get a parasternal short axis. I really like this view because it shows what's going on, how we have that tamponade physiology. As the heart is in diastole and relaxing and lengthening out, we see that right ventricle collapsing down. Sometimes it may be hard to see that RV collapse, especially in that first case or that first clip. Couldn't really distinguish the RV very much, but in this one we have that nice view of that right ventricle wall right here, and as the heart is relaxing, the RV collapses down. So an apical four-chamber view, again, large pericardial effusion. That right side is just getting smashed down by all the pressure inside the pericardial sac. So the signs that we look for, much more simply than pulmonary embolism. There's many signs of like right heart strain that we can look at and try to identify. With tamponade, it's pretty straightforward. There has to be a pericardial effusion, first of all. one of the first signs you're going to start to see is the IVC is non-collapsible. It's going to be very plethoric, not collapsing down with respiration. You can measure the mitral valve inflow velocities, and as they take a breath, you'll see that kind of vary a little bit. That's consistent with the pulseless paradoxus. You'll have that drop in blood pressure as they inhale. As intrathoracic pressure decreases, it's going to have decreased preload on the heart. They're going to have less blood flow moving through it. You'll start to see right atrial collapse and systole, and then finally you'll have that RV collapse and diastole. And that's kind of like my stopping point. If I'm seeing that, as we did in this patient, we kind of stopped everything and then started prepping her for pericardial centesis. So stop right there, take action, and you'll see huge changes. So in the clip that I showed earlier, it was hard to tell, was there really right ventricular collapse and diastole? So one thing we can do is put the machine into M mode, put that cursor through that right ventricle, through the septum, through the left ventricle and that mitral valve, and we can trace this over time. So this tracing here, this waveform, that's the mitral valve moving, and as the heart enters diastole, you're going to see that open up, flap towards the septum, and then once the heart contracts, it closes and sits here in systole. So if you're looking at the RV here, we're not seeing a nice black opening where the ventricle is. If you're seeing this free wall collapse down as this is opening up and they're touching, that's going to be your right ventricle collapse during diastole. Another thing you can do is just save a clip and slow it down. Just replay it in a slower, you can go frame by frame and try and see the same thing. When those valves are open, what's the right ventricle doing? So we have some options of how we can approach the pericardial centesis. If we opted to go parasternal on her, so in a normal model, that lung is going to be kind of overshadowing the heart. But in her case, that pericardial effusion was so large, it was displacing the lung laterally. So she had a very big window that we didn't have to worry about causing any kind of pneumothorax. So there's lung there. You have the internal mammary artery and vein that are lying right next to the sternum. So those are, potential complications for hitting those there. The other option is, doing a subxiphoid approach. You're going to have the liver, but if you're going a very superficial plane, you shouldn't have much that you're going through and may not even injure the liver. So we have to go for a kind of a parasternal short view. We have this big area of fluid here. Again, as we play the video, there's no lung that comes into view and shadows anything, so we're not concerned that we're going to cause a pneumothorax. So we just anesthetize the skin, get our pericardial centesis kit. You can do a central line kit as well. Put a wheel on the skin, watch your needle under ultrasound guidance. I'd recommend using a linear probe if you're going to be doing this, and you can. A linear probe, so you're going to have better visualization of your needle. Get into that pericardial space, and with as much buffer zone as you have here, you're going to have very little chance of actually hitting the heart as long as you're aspirating as you're going in. So we did a kind of a parasternal short view as we went in with the pericardial centesis. So notice the time there, we're 5:50, and we're finally getting to the pericardial centesis. So she's almost 3 hours into her visit when we finally get the actionable interventions that are going to save her life. So we pulled off a pretty significant amount of fluid. So she had over 600 cc's of this serosanguinous fluid that we pulled out. As we were pulling the fluid off, you can see the change in her vital signs. So here's 5:50 right here, the same time that was on the clock. So she was on Levofed, and as we were aspirating, she had this sharp jump to 133, 157, 142, and that heart rate starts dropping down. Like these are, as we were doing it, the resident said, "Hey, I guess we can shut off the Levofed." everything's turning out better. Her color looks much better. She was starting to be more alert, talking. You could just see the life actually coming back into her. And then this is the result. So you can see how much larger that heart is now. We can see clearly that there's no right ventricular collapse when the heart is in diastole. As the mitral valve leaflet comes up and hits the septum, there's no collapse there. She still has a large effusion. We left a pericardial drain in place, and over the next few days, cardiology came to the ICU and would take off, 100 or 200 cc's as needed. But these are the reasons that we do ultrasound in critical patients. Right away, we'll identify what's causing her to be so shocky and hypotensive. Right away, we know we need to do an actionable intervention to save her life, and we can, move on and go deal with other things, deal with the rest of the department. Yeah, it's going to take some time. It's going to be very, we were all sweating bullets. It was the first time that either of us had done this procedure. But just like in a pneumothorax, you got to put a chest tube in. This is a life-saving procedure that needs to be done right now before that patient goes anywhere. We're lucky that she didn't code while she was in the CT scanner. We're lucky that she didn't code just at any other time with how unstable her vital signs were getting. That's it. I think we were in the fourth intercostal space. So like right where we would put the probe for our personal long and short views, we were just right there. So we just left the probe right there, just a little bit off to the sternum, so we didn't hit the internal mammary artery, but we didn't want to go too far lateral that we were getting into the lung. So we knew we had some movement, and if you scan over, you can see how far, you can track over how far that lung will start to come into view, and you can actually track how big that pericardial space is that you're going to intervene on.